Okay, I stopped part three early because I realized I had made a mistake on the slide when I was copying and pasting to get the correct font. My fault. Um, I had that beta blockers increase contractility, and we all know because we've all passed pharmacology that that was wrong. That Jean Marie was a big old loser and should have checked that earlier. But in my defense, someone else whom will remain nameless also checked my slides. But I digress. So, beta blockers used with chronic heart failure. They are commonly used, and the reason they are used is because it prevents the harmful effects of the sympathetic nervous system stimulation. But they are used in low doses because beta blockers decrease or reduce the force of myocardial contraction. But they are used in low doses because they help to prevent those harmful effects of the CNS system. Um, so, some of the side effects of these are hypotension. It can cause bradycardia, especially at night. Um, and they can have some drowsiness. But because it decreases the effects of the sympathetic nervous system, is why they are used in low doses with chronic heart failure. But remember that they decrease the or reduce the force of the myocardial contraction. So I hope that doesn't confuse anyone. I did update our slides. Okay, so digoxin is an older medication that is not used as commonly anymore, but is still used because it's an older and cheaper medication, and it improves cardiac performance. It is a positive inotrope, which means it increases myocardial contractility that allows the ventricles to empty more completely with each heartbeat. So what Ditch basically does is it slows it down and lets it give a big squeeze to get more blood out. So that's how Ditch works, is it slows the heart rate and then gives it up so that it can give a bigger squeeze to get more blood out with each heartbeat. Some of the reasons that digoxin is not used as readily anymore is because it has a very narrow therapeutic window. Um, its therapeutic window is between zero point 0.5 and 2. Anything greater than 2.5, the patient can be considered digtoxic, which can produce green and yellow halos around objects and slows down the heart rate to dangerous levels. So anytime before you give digoxin, whether you're giving it IV or PO, you want to make sure that that heart rate is at least 60. So that's some of the reasons why they're not using DIG anymore. It's an oldie but a goodie, but you will see it used in areas where people's medication, where their secondary insurance with their Medicare is not the greatest, or maybe their Medicare, Medicaid. They still use DIG because it's cheap and easy. As long as they keep that blood level within that therapeutic range, and they know to check their heart rate prior to taking it, and make sure that they keep a good eye on their potassium levels. People do very well with DIG. It just has a lot more. There's other medications that people are using more often now, but it still is used a lot with people who can't afford their medications. Increasing, continuing on with the care of the patient with heart failure. Um, you want to talk to them about ways to decrease their fatigue. Um, the beta blockers make them tired. So energy management, talking about how they can work with their activities during the day. Um, some some cardiac rehabs have heart failure clinics where they allow these patients to learn how to exercise in a controlled environment and help them be able to get to their optimal level of health. We need to talk to the patients about pulmonary edema, about if their cough does start to get wet and frothy, um, because the goal of chronic heart failure is to prevent pulmonary edema. And the way we prevent that is by monitoring our weight so that the patient doesn't get to where it's filling up into the lungs. Make sure that they're taking their medications appropriately, and make sure that they don't run out of the medications or double up, because pulmonary edema is an acute problem and is life-threatening. Now, what I mean by core measures is these are determined by the Joint Commission of Hospital Systems. And so these are things that have to happen with patients with heart failure prior to going home from the hospital. They need to be on a low sodium diet. They need to have they need to know that not only know what activities they can do, but also if available, they need to be able to talk about cardiac rehab or increasing their activity to optimize their wealth. They need to have a weight monitoring system, talking about daily weights, and where they either call them into their physician's office or a heart failure navigator will keep a track on that. They need to make sure that not only do they have prescriptions for their medications, but ways to get their medications and understand what to do if they're not able to get their medications. They need to have a plan for what they're doing when their symptoms worsening. When do they call the physician? When do they need to come to the hospital? But mainly with these patients, we're trying to avoid hospitalizations, especially in that 30-day window. So they'll talk about making sure that you're contacting your physician. They need to have their left ventricular systolic function evaluated. They need to be on an ACE inhibitor or an ARB for left ventricular dysfunction, systolic function, excuse me. They need to have smoking cessation counseling, and we need to make sure that they have follow-up care. So that means not just making sure that you don't tell them, well, you're just going to follow up with your primary doctor. You have to make sure that they have the office visit already made, and you need to make sure that we know that what kind of transportation they have to get to that appointment as well. And those are all parts of the core measures when talking about when talking about heart failure. Nursing considerations. Nursing considerations and teaching. We've already talked about making sure that you take your medications as prescribed and not running out. Make sure that they know not only the side effects, but the purposes for why they take them. Avoid nonsteroidal anti-inflammatories to prevent sodium and fluid retention. One of the reasons they go to cardiac rehab is so that they can learn what activities they can do. But basically, if you can't talk, you need to rest. So as tolerated, you have to be able to talk normally during activity. Weights, we talked about daily in the morning. Diet, low sodium. Sometimes patients will be on fluid restrictions, but usually it's limiting that fluid to about 2,000 a day. And if you become symptomatic, don't wait. You need to contact your provider. So these are just some cute little reminders of things we've already talked about. So nursing interventions, we talked about educating on that low sodium diet, that 2 grams a day. We talked about making sure that they weigh daily, where it's just them on the scale, and that it's the same time every day, and they void before they get on the scale. We talked about exercise. We talked about making sure that they had periods of rest. And these will all help to the patients to live a more productive life with their heart failure. We need to talk to them about their smoking, make sure that we've gotten them into a smoking cessation program, limiting their alcohol intake, limiting their fluid intake in general. We need to talk about stress management. We need to make sure that they know ways to decrease their anxiety. And again, it's so important to make sure these patients know not only why their medications are important, but we need to make sure as their nurse that their care team to make sure that they are going to be able to afford their medications. These are all very important. We also need to look at make sure that they have finances to afford their medications, and also transport to get to doctor's appointments routinely, and make sure that they have those follow-up appointments. And that's all for heart failure, guys.